Good morning, everyone, and thanks for joining us for today's OCL update webinar. We will just go through some quick housekeeping things before we get started. We are recording today, so please be cognizant of any personal or protected health information that you are sharing, either verbally or in the chat. Please use our chat panel today to type in your questions as we have them. Our team is managing your questions there. You can get a copy of today's slides. They are available on our website, and we'll put that link for you in the chat so you can go and grab those as you need to. If you are listening by phone only and not in the video portion of the meeting, you can still participate by pressing *6 to mute and unmute your phone, or press *9 to raise and lower your hand, and that you'll be added to the queue. And Zoom does provide closed captioning. If you click on the live transcript button at the bottom of your screen, you can either turn that on or off. And with that, I will turn it over to Julie Riskin to start us off.
Thanks, Jen. Good morning, everyone. And clearly my dogs have something to say about this. So I apologize for that. What we're going to do today is we're going to start and end with a member video, which is something that HCPF is doing to get the member voice more in the public eye, which I think is really exciting. As someone who's, proud to be a Medicaid client, I think it's always great when we are spotlighting people that use our Medicaid system. It humanizes it and makes it, normalizes it, which is great. And given that I think at this point, 1/3 of Coloradans are on Medicaid, or a quarter, a lot anyway. I think that's great to make sure that the client voice is more central. Then Colin and Ryan are going to talk about just some things that they're implementing and changes around things having to do mostly with case management. Then Colin and I will go over legislative and budget changes that affect Medicaid or that affect the disability community. Obviously, we're not going to cover every single bill, just a few highlights. And then we will have another video, and then we'll end, as always, with upcoming events and reminders. So with that, I'd like to ask Sarah Eaton to come on and do whatever you need to do to share your video, please.
Thank you. Thanks for having me at this meeting. My name is Sarah Eaton. I'm the Deputy Client Officer at the department, and one of my major roles, I guess, in my job is to facilitate the Member Experience Advisory Council, and that is where the idea for these member spotlight videos came from, and I'll talk about that in a minute. But if we could move to the next slide. You're getting a sneak peek today of a new video that is not live for the public yet. So if we could let's just go ahead and play the video, and then I'm just going to talk a little bit more about the project for a minute.
Go to your bed, please. Thank you. There you go. How do I say this? So basically, I got a virus and I never got better. Think of it as like a broken cell phone battery. Maybe I only charged to 30%. Doing a load of laundry can put me out for a week. I might not even be able to finish that load of laundry and I would be out for a week. I was just sent for testing after testing after testing after let's try this, let's try that. And that meant I was constantly receiving medical bills. And so every time I went to the mailbox, there would be a new one. It was like this huge weight lifted off of my shoulders. There's no more $1,000 hospital bills. If I have to go to the ER, there's no more calculation between me and my husband. How much is this going to cost? Maybe we don't go this time. With Health First Colorado, I get control over my life again. And when you left that message, it was like the sun shining on my brain and heart for the first time since March. It takes energy from me. I've been tired lately. I haven't been sleeping as well. But when I hear from patients that what I did mattered, I had messaged them to thank them for their kind comment, that it means they get better medical care, that days are easier for them and their families, and that they see a light at the end of the tunnel. It was so good to talk to you. That matters to me. I'm so grateful to you. Thank you. That's one of my favorite messages. So I really want people to know that Health First Colorado can be an option for them. It is an option. It changed my life, and I want other people to have that same access.
Great, thank you. And thank you, Julie. I think you were the connector
Yes.
with Allison, so appreciate that.
Yeah, Allison is part of our Ray 1 Larimer County Client Council.
Yeah.
So yeah, so she's awesome, and she's done a huge amount of work helping people with long COVID.
Yes, we talked about that a little bit. She's amazing. I love that. And in a lot of these videos, we're showing kind of how Health First Colorado supports members, but also how members are supporting others, which is just amazing. If we could go just to the next slide, and I'll just quickly share with you. Just as I said, this idea came from the Member Experience Advisory Council, really for just what Julie said, to help humanize the experience, help people feel less alone, help to reduce the stigma of being on Health First Colorado, and share the impact that Health First Colorado has had on their lives and their families. So we have been doing this since 2019. We've got 15 videos so far. We're continuing this. We've got ongoing funding to support this project, which I'm really excited about. So my ask for you today is, if you have a story you would want to share, or if you know somebody who might want to share their story, we've got a form online that you can complete, or you can just reach out to me, and we will.
Also, Max just put it in.
Great. Awesome. Thank you, Max. So this will pop up again when we look at our video later on at the end of the webinar, but would love to partner with anyone to tell more of these stories. So thank you so much, and I'll see you in a little bit with another story.
Great. Thanks, Sarah. And I'd encourage people to reach out to your friends too, if you know of people, because I do think that our contributions as clients often, again, are not seen. And so I think particularly featuring of people who can use the fact that we have our Medicaid program to show that all of the things that we are able to contribute because of being able to get our needs met. So MEAC is Member Experience Advisory Council. Thank you very much, Jerry. So I'm going to turn it over to Colin and Ryan to go over some of the things that that they're working on right now.
Thanks, Julie, and thanks, Sarah. I've seen that video several times, and every time it's just so powerful. So looking forward to seeing another one at the end. We'll hope you stick around for that. If we could go to the next slide, please, Jen. So a couple of exciting changes I wanted to get to up front, and then we'll talk a little bit about the assessment tool, next steps on that. I know Julie had some things to add to that conversation as well. But as many of you probably or hopefully remember from last session, so this time last year, we were having the bill signed around the spinal cord injury expansion. And what this means and what this looks like is really exciting. I think a great opportunity for our members and for our case managers, others to get involved and really help spread the word about what I think will be a really fantastic set of services. So the SCI waiver, or what will formerly be known as the SCI waiver, will become the Complementary and Integrative Health Waiver, or CIH waiver. Jerry will make sure that we will not use the acronyms on that, but that will be available statewide. And what we're doing with that as well is expanding the eligibility criteria. So now it will serve people with the spinal cord injury. Obviously, it'll keep that base set of individuals, but it'll serve people with multiple sclerosis, spina bifida, cerebral palsy, a brain injury, or muscular dystrophy. Obviously, there has to be a diagnosis, sort of with that base set that results in the inability for independent ambulation. But we do expect many people to be able to come on that waiver across the state of Colorado. So our team is actually going to different parts of the state, going to be doing some trainings with case managers, going to be doing some community meetings, talking with different stakeholders, different advocacy organizations in those areas, trying to get people to learn more about it and be able to spread the word there. So the informational memo will have more information if you're interested, and then we'll have an FAQ, or the FAQ is actually already up. Thank you, Candace. That name change for case managers and others won't go into full effect until we have the care and case management tool go live. So it'll still exist as the SCI waiver, but for all intents and purposes and with the federal government, it will be considered the Complementary and Integrative Health Waiver.
Yeah, and I just wanted to make sure people understood that you can still get like CDOS and transportation and your other services. This just adds acupuncture, chiropractic, and massage. Is usually people use those for either pain management or better like range of motion and mobility. So you could add those, but you don't lose other services by going to this waiver.
Yeah, thank you, Julie. That's a great point I should have mentioned. So this waiver really is just, it looks a lot like the EBD waiver. In fact, it has the same service set. The only difference is it has those additional 3 alternative therapies, so massage therapy, chiropractic care, and acupuncture. So thank you, Julie. With that, I'm going to turn it over to Ryan briefly to walk through a new memo and change for case managers. If we could go to the next slide, please.
Great, thanks, Colin. Can you hear me?
Yep.
All right, perfect. So memo, operational memo 22-030, in-person change for case managers, has recently been posted. It is resuming in-person case management activities effective August 1st, 2022. What this change is bringing right now, we have some case management agencies are performing in-person case management, and some are performing virtual, with really the member and the case manager agreeing as to whether or not it will be in person or not. This change will be moving where the case management agency will offer in-person contact to all members, and the member will make that decision as to whether or not they want to continue virtually right now during the public health emergency, or if they want in-person case management. So this will begin on August 1st. In terms of this, case management agencies have been notified, and they're gearing up, developing their plans for how they're going to ensure that they're taking safety precautions, making a plan for wearing protective equipment, any mask wearing, any meeting outside, their own case management policies and procedures around this. And then they also must follow all Colorado public health orders, including requirements for state contractors and any local public health orders. So this will be effective on August 1st. So we're very excited. We had many listening sessions with case management agencies, members, family members, really expressing that our members wanted choice to be able to resume in-person contact. So that'll be rolling out shortly. Thanks, Colin.
Yeah, thank you, Ryan.
Thanks, Ryan. Yeah, we had a lot of people saying that they felt they needed in-person case management because not everyone is good with doing everything in front of a screen. So I think, and particularly in rural areas where there isn't, we saw some negative consequences for people not having those eyes on. So, okay, what's next?
Yeah. All right. Thank you, Ryan. I'm going to run through the rate increases quickly. We do have a pretty big agenda today, and I want to make sure we have enough time to cover the budget and legislative stuff. So A couple updates on rate increases. So following this legislative session, there was an across the board 2% increase. That is in addition to the item within the long bill that actually sort of codified and will continue the new base wage of $15 an hour. So between the two, pretty significant investments there. In addition to that, we had some targeted rate increases around massage therapy, group home / foster home for our CHIRP waiver, our Children's Rehabilitation Residential Program waiver. Our respite unit was increased within that waiver as well. We did have some NMT increases or non-medical transportation increases, specifically in the SLS and developmental disability waiver, supported living services waiver. Those are in line with what the Medicaid Provider Rate Review Advisory Committee had found, some recommendations there. And then 2 increases specifically for our brain injury waiver. One around our transitional living program that created a single tier. That is our, for those of you who maybe are not aware, that is our post-acute residential service that allows people who are in that anywhere from month to 18-month stage of recovery following that brain injury. There's a lot of research out there that says some of the more kind of hands-on programs are really critical to ensure people can kind of meet their best recovery within that period of time. So excited to be able to increase that and sort of make it easier for our providers, members, and our case managers. And then our supported living program will now have a negotiated rate for some of our more complex individuals requiring services there. If they have some behavioral needs as well, we're looking to try to make things easier for, again, our members, families, case managers, and our providers. So a lot going on there. There will be, if we could go to the next slide, please. There will be memos on a lot of those things. There will be the new rate sheets. I believe some of them have already been posted. This timeline is really helpful. I'm not going to go line by line, but this sort of talks about and shows all of the various things that are moving forward. So we have the ARPA increases, we have the 2% common policy increases, we have the temporary respite increases that ended this spring, and then we have that new base wage. And so this is a helpful way to keep an eye on all of the things that are moving forward. It is our goal certainly to try to make this as easy as possible, but with some of the funding that is tied to ARPA and the way that we have to get these approved, it does make it complicated. So if there are any questions, certainly please email us at the HICPUF_HCBS email, and we will get back to you as quickly as possible with any questions on timelines. And yes, Jerry, that supported living services is the same as DD and SLS. Thank you, Candace, for posting that in there. And if I could run through a couple federal updates real quick. Next slide, please. So many people have likely seen that we are, as a state, now allowed by CMS to receive a 1-year extension to our American Rescue Plan Act Section 9817 work, which is just kind of called here in Colorado the HCBS ARPA plan. What this provides is a continuation for that additional year until April 1 of 2025. And so with that, there has to be a continuation of a maintenance of effort. There also has to be a continuation of funding. And with this, there's not any new funds attached with it. It's just spending these existing funds within that additional year. And so the department is looking at the pros and cons of that. We're working with CMS. And then we have our American Rescue Plan Act team or ARPA team on that, doing some analysis as to whether or not we should proceed with the delay request, what that would look like, sort of what projects would fit under there. As Bonnie is typically the one to say, we had, when we initially got this, about 2 years and 4 months to do about a decade worth of work. And it's our goal to continue on that trajectory to get that work done as soon as possible. But there are a couple things that we're looking at that may require us to have thoughtful conversations around whether or not there should be an extension. So we'll have more to come on that likely this summer as we work with CMS and provide some analysis there. We'll have some conversations with stakeholders, and I would imagine in our July update around ARPA, we'll have a little bit more about where we're at and what we're hoping to do there. We could go to the next slide, please, Jen. Also from CMS was the Home and Community-Based Service or HCBS settings final rule extension. This came out largely because of states who had stated there were issues around completing the STP or statewide transition plan with the COVID pandemic. And so what they've allowed is some additional extra time if it is affected or had been impacted by certain criteria within the PHE or public health emergency or the corresponding workforce crisis. And so it's still our goal, much like with ARPA, to get this done as quickly as possible. We'll certainly have some additional considerations there. But the one caveat here that is sort of unusual that I think is giving us some additional pause is that it would require each state to go on to a corrective action plan. And what that actually means for the state, its providers, and the members who are subject to these requirements within that final settings rule is additional reporting, additional administrative work. And so we're really weighing the pros and cons of that. There's again some analysis that we're working on. We're having those conversations with CMS and ultimately hoping to make a decision here in short order. At the end of the day, though, we want to reiterate, whether it be to our stakeholders, our advocates, disability community, or our providers, is that our goal, our North Star on this is we are going to implement this to the fullest extent possible as soon as possible. And if there are any things or caveats that are sort of out there hanging, we'll work with you all on that. We'd like to hear that, but we are moving forward. It's been at this point over 8 years and 2 months, 3 months, but who's counting, since that has come out. And so we want to make sure that we're moving forward to get that done and get those settings in place. Go to the next slide, please. So I wanted to just kind of run through this real quick, and then I'll turn it over to Julie, and we'll certainly leave some time for questions. So the department is putting forward tentatively in July a rule change around the Colorado single assessment or the level of care screening rule update. And this will give us the ability to go forward with a soft launch. And in our analysis and working with Amanda, she'd kind of given me the background on this. The soft launch will allow us to begin to use the newly automated system and begin to, on a small scale, identify and address any system design flaws or defects. It'll allow us to develop and provide training and receive feedback on that training, incorporate additional things that we think needs to be in that before go live. It'll create opportunities for case managers and those case management agencies to familiarize themselves with the system. It'll get us some data that we would love to be able to collect and understand what the average length of time for the new processes to happen as part of this system. So from beginning to end, what that looks like, be able to plan that out so we understand how those timelines should look and how they would impact people. And then review completed single assessments or level of cares for inter-rater reliability. So actually take those data sets and compare them, make sure that they're accurate and scoring people correctly. And then the rule change allows us to use a new process for members in participating with the soft launch that have not had to use both the ULTC 100.2 and the new level of care. So the members who participate in the soft launch will have the same appeal rights. So that will go forward. They'll have that same process if they are on that additional cohort. That said, we recognize there are some concerns. And we will have the ability, and I put the timeline in here, we'll have the ability for people to give that feedback if there are some additional concerns. Ultimately, in talking with Amanda and her team, she did say if there are concerns and enough conversation that warrants it, we will delay the rule reading until August. Certainly, it's our hope to move quickly so we can start gathering that data. We can start, doing that inter-rater reliability. But the goal for the conversations that will happen the rest of June and into early July really is to listen and make sure everyone's on the same page. And so, if we can't come to, sort of an agreement as to be able to move forward, we'll have a delay there. But wanted to make sure people feel like they can be heard. So here are some options. If we could put the Candace, if you could put the email back in there. If you would like to hear more or get contacted directly, please reach out to us. We're happy to do that. And with that, I'll turn it over to Julie. I know Julie wanted to say a few words as well. And then Jerry, I'll answer your questions as Julie is finishing up.
Yeah, thanks, Colin. And yeah, that was the conversation that Amanda and I had, and CCDC and I believe a number of other advocates and advocacy groups had concerns because we haven't seen the tool because there's been some issues with automation. So we haven't seen how it works from start to finish, those of us who have been working on this for many years. And I think we felt we just needed to see it before we could support a rule. And what we had talked about is having a group of people go through the tool as volunteers, understanding that it would not be in lieu of the ULTC 100.2. It would be that duplicate, or it might not even be at their normal assessment time. And so to allow the department to allow just some starting to use it, and that would also help us see how it worked. And so that might be a compromise. So if we do it in August, we could still start in July doing that, because just doing a pilot or like mock assessments does not require, or you don't need a rule to do that. It's only if they're quote unquote the real assessments that they would need the rule. And then you could just go through and hopefully, we'll have the automation and everything done so that we can see it, that our expert can get in quote unquote under the hood, and that we'll just kind of know how everything's going to look. So yeah, that was the conversation that I had with Amanda just a couple days ago. And again, the problems with the automation is I don't understand all the technology behind it, but that's why we haven't seen how it looks, like how it would look for a case manager, how it would look for a client from start to finish. We just know what all the questions are.
Right.
So thanks.
Yeah, no, thank you, Julie. And again, certainly invite anyone to participate in those conversations. I know Julie has those ongoing conversations with Amanda, but if anyone else would like a deeper dive or the ability to talk with our case management team, please let us know. With that, I think we have a quick question or discussion break. If anyone has anything they'd like to talk about that we've covered thus far that we didn't have an opportunity to hear from you all on. Okay. Well, with that, if we go to the next slide, please, I'll move into Julie and I's legislative and budget recap. Julie has a couple things that she'll be covering that I would otherwise cover, but with that, I wanted to start with the budget side of things, as that's usually sort of the first item on the docket is, we do that JBC hearing, briefing and hearing every December, go through sort of what our big items are. OCL had another kind of big agenda this year. So we had a series of budget requests improved, considered kind of program enhancements. So we were able to expand the home delivered meals benefit to actually serve people outside of the transitions program, which we're super excited about. Right now, having conversations, recruiting additional providers, but something that we're very eager and willing to expand across the state. So looking at different geographical areas, making sure that we can expand it just outside of the Metro Denver area. So looking for partners in that work. If anyone is interested, please let us know. As I had already mentioned, we increased the rate for the transitional living program. We created a negotiated rate for the supported living program. We aligned the rates for several case management activities. So looking sort of across how people receive case management, being able to true those rates up so people are receiving the same rate for those services. We're not incentivizing any under access in some of those areas, which is great. And then aligning service limits and rates between the CHIRP waiver and other waivers, including our CES waiver. And that was really important to be able to, again, recruit providers. And then maintain current funding and enrollment levels of the state-only programs for people with IDD, another thing that we needed to put forward. Those general fund only programs serve a lot of folks, and we wanted to make sure that we had the ability to continue that work. And so that was part of our request within that program enhancement bucket this year as well. Go to the next slide, please. Sort of already talked about this, but the provider rate adjustments, that actually the 0.5% is what we requested. We actually got a 2% increase there. We adjusted member contributions for co-payments and personal needs allowances, trying to make that easier on our members. We continued the $15 an hour base wage requirement, initially funded through ARPA. So I know a lot of individuals in our conversations about ARPA were worried sort of about that cliff with the $15 an hours. Our new base wage, we were able to get that to continue, and looking forward to as we get that analysis back on the direct care work and this reporting, which I'll talk about at the end of the meeting, looking forward to understanding the impact that's made and additional strides we can make to support our direct care workers here in Colorado. We increased rates for massage therapy, NMT, and speech therapy. And then we rebalanced rates for the DME benefit, or the durable medical equipment benefit. There was a lot of actual work on DME this year. I'll let Julie speak to that. So a lot of really exciting stuff there as well. We can go to the next slide, please, Jen. Just a quick one. I know this is of interest to some folks. We were able to get some additional compliance FTE to be able to boost our kind of qualitative control over programs, make sure that we had the checks and balances in place. And so we were able to get an Olmsted person at HICPUF full time. They will be working on Olmsted, which we're really excited about, having sort of that one person, one individual here at the department that can be the source of truth for all that work, and really combine all the efforts across the department to make sure that we're compliant with Olmsted and we're moving towards true community integration. We got an FTE to improve the PACE program oversight, which Julie will talk about a little bit more towards the end of her presentation. We got an FTE and some contractor resources to go forward and administer supplemental payments for nursing facilities. So again, that quality metric, making sure that we're doing that pay for performance correctly, bringing some accountability to the nursing facility world. And then we got one FTE to manage the nursing facility civil monetary penalty fund, which is a fund that is from fines to nursing facilities that we use then to create behavior change in nursing facilities. So put forward person-centered practices, do different trainings outside of what normal sort of trainings would be associated with nursing facilities, talk to individuals about community integration, things of that nature. So able to really do some evaluations as to how those programs are working, and I think take the innovative step to ensure that we have more meaningful engagement there as well. Sorry, Jerry, FTE, as I said up front, is a full-time employee. So it's a person who will be working at the department. Sorry about that. If we go to the next slide, please. We also were able to get our ARPA spending plan reapproved, so able to spend that for this upcoming fiscal year, which we're very happy about, obviously. That 530 plus million is a lot of money to spend, and again, that about 2.5 or 2.25 years time. So looking forward to getting that out as quickly as possible. Go to the next slide, please. And then I wanted to mention this. This was something that sort of was very early on in the session and kind of wasn't talked about as much as we sort of had expected at the beginning. But the conversation that we had, the start of session, really great conversations with stakeholders around the reimbursement for therapy using equines or equine therapy. And what we're going to do is, subject to federal approval, we're going to be able to reimburse therapy for equine movement, whether that's a PT, OT, or SLP, or physical therapist, occupational therapist, or speech language pathologist, if they provide or sign off on that therapy. So looking forward to expanding that benefit. We're going to be working with our friends over in the Health Programs Office that runs state plan Medicaid to ensure that there's some disability cultural competency there. But again, one of those items that sort of slipped under the radar that will hopefully have a big impact to the long-term care population in years to come. Go to the next slide. This session, as Julie will talk about, really was, though, overall focused on behavioral health. So I wanted to talk about 3 bills here. Julie will talk about a couple more, including the BHA, which was sort of the centerpiece of a lot of this work, and certainly part and parcel of the last one on here on my list. But the first one, the Behavioral Health Crisis Response Training. This bill amends the timelines. This was a previous bill last session. It was House Bill 1166. This year it's 221189. So glad to get to keep the 11s there. But what this does is directs the department to obtain a vendor to conduct statewide training for up to 20 professionals to work with individuals with an intellectual or developmental disability and a co-occurring behavioral health need. So getting these people in various organizations on the ground trained to work with individuals who have that co-occurring need. What had happened was last year, there was a solicitation that went out. Potential vendors we heard from were not available at the time to respond. So we just sort of changed the language in the bill, reworked the statute a bit, and we'll be doing another solicitation here this fall, late summer, early fall of 2022, and get that work started, looking at how to kind of create a pilot out of that work and sort of hopefully be able to recreate that in the future. And then we have the Youth and Family Behavioral Health Care Bill, or House Bill 221283. This bill provides funding to CDHS, or the Department of Human Services, for the development of a 16-bed neuropsych facility for children. It'll have these facilities, or these residential settings in all 7 regions of our state as it's broken out. It'll be administered by the Behavioral Health Administration, and they'll actually, my understanding is, as they work through this, begin to add substance use treatment beds to these settings to ensure there's sort of a nice mix of the ability to meet individuals' needs across the state. So looking at, again, those youths and making sure that we're providing the care that we need across the state in those geographical regions. And then the last one is something that I know I had worked very closely with the Department of Human Services, soon to be the Behavioral Health Administration, on, which is increasing residential behavioral health beds. What this does is it requires HCPF and CDHS to work together to jointly create 125 beds, half of which will be home and community-based service in nature. The other half will be behavioral health entities under the new license type. But this will allow for people to potentially come out of the Colorado Mental Health Institute at Pueblo, be able to step down, go into the community, receive those supports they need. Again, those HCDS beds, they will look a lot like alternative care facilities, or ACFs. And so Candace and her team are busy working on this with CDHS right now, and we'll have more information in the new fiscal year on timelines and what that looks like. We just had our initial kickoff meeting a couple weeks ago, so more to come publicly on that. We can go to the next slide, please, Jen. So to the direct care workforce efforts, staffing has obviously been a huge issue across the board. One of the areas we have heard about in particular is staffing agencies and how they operate in Colorado. And so the legislature took on the issue, and they're going to be working with CDLE, HCPF, CDPHE to come up with a way to actually license them or certify them under CDLE. So they will no longer just be an independent entity. There will actually be a way to understand how many organizations are in the state, what they're doing. And then it will also kind of look at what the wages and rates are. What are they charging organizations? Are they, maybe in one area charging a lot of money that is causing access to care issues? Are they, maybe in some areas taking additional CNAs away from another organization? And so those are the things that we're looking at, not wanting to squelch or stop any competition, but wanting to make sure that it's a level playing field when it comes to some of our certain provider types, nurse aid being one of them, RN, PDN, or LPN, excuse me, and others. So we will be working on that as we move forward into the new year. And if we could go to, actually, I think one more, I'm sorry. Go to the next slide, please, Jen. And then the last item on the staffing overall kind of workforce issue is we are going to put forward and work with our friends over at DORA a fee relief for nurses, aides, and technicians. So that will be that fund will be available beginning this next fiscal year until it's fully expended. Work through the State Board of Nursing. It'll provide, again, fee relief for nurses who are regulated by that board, nurse aides, CNAs, for example, LPNs. They will have the ability to receive some relief when it comes to those fees. And then license registration fee relief for mental health professionals, sort of exact same setup. It will be a fund, be available until it's fully expended, but that will look at providing fee relief for examiners, social workers, therapists, licensed family therapists rather, counselors, and psychotherapists. So there's sort of a large swath of individuals that are looking to help there. In talking with Dora last week, they're going to put out some information here. If it hasn't gone out this week, it should go out shortly, that people can access. We're looking to really share it with networks, share it with home health agencies, share it with different facility-based services as well. So if you were able to distribute to the network, we'll make sure that goes out in one of John Barry's emails here shortly. And with that, I will turn it over to Julie.
Okay, thank you. You can go. I'm going to talk about a few different areas, starting with behavioral health. If you can go to the next slide. So there was a bill on the crisis system that was initially focused on telling the crisis system that they had to provide services to people with substance use disorders, and we got it amended to include people with disabilities. And so what that says, and I put the exact language, they have to serve anyone with a disability regardless of primary diagnosis or co-occurring conditions, or if the person needs assistance with activities of daily living. And they also have to do everything in their power to serve people in the highest level of crisis without the use of law enforcement. We've gotten a number of complaints over the years of people with disabilities being turned away from behavioral health services, particularly when they have developmental disabilities or brain injuries. And the providers would say, oh, well, the reason they're having this problem is not a mental health issue, it's a developmental disability, which is ludicrous because we can't pick our brains apart that way. Things just go together. So this means that they can no longer, I assume as of July 1st, no longer refuse to serve our community when they call for crisis because of disabilities. We also have had people with disabilities denied access to those like little respite crisis places where you can stay for a couple days if they needed, even if they just had medical issues. I mean, we had someone once denied because they had an insulin pump, which is ridiculous. So those are that hopefully will become a thing of the past. Of course, we're going to need to stay on top of it, monitor, and let people know that this discrimination is no longer going to be allowed. If you can go to the next slide. The Behavioral Health Administration, this was a 220-page bill. So there was a lot that went in it. It was House Bill 22-1278. It was a very good process, a very wide group of people, all of whom wanted to see a dramatic change to the mental health system that we have in this state. All of whom agreed that what we have is not working, and we can't just have certain privileged providers, which are the community mental health centers, basically just kind of getting money and without really having accountability, and then everyone else just kind of gets pushed out of the system if that's not working. So it was, rural county commissioners, mental health advocates, all different kinds of people that wanted something very, very different. We got a lot of amendments in there, that a lot of language that we wanted around disability, particularly prioritizing people with serious mental illnesses and others that are historically underserved, which of course includes people with disabilities. There's a lot more accountability, and one of the things I really like is that providers are not allowed to dump, quote unquote, difficult patients. So one of the things that providers always use to not serve us is they say, well, what your needs exceed our capacity, or we don't have the expertise to meet your needs. So if they say that now, they have to find you someone that does meet your needs, and they have to keep serving you until that is secured. I think that hopefully will make it so that they can't just dump people, which is what they've been doing for years. There's also more accountability about governing boards of providers. They have to involve clients. That's never been something they've had to do. It's interesting because federally qualified health centers have always had to have 51% of their board be clients, and mental health centers haven't. And I think there's a big difference when you have clients on the governing board. It really helps. So there's a lot more in this bill, but we have limited time. And like I said, it was a 228-page bill. There were a lot of meetings about this, and all of the things that we asked for around disability got in. They're also removing all language about primary diagnosis. They're removing language about having a developmental disability doesn't mean you have a mental illness, because that's just gotten in the way. So all of that language is no longer going to be in the law, which is great. If you can go to the next slide. There were 3 transportation-related bills that are relevant to our community. One is House Bill 1114, which I'm really excited about. That's going to, beginning in 2024, we're going to be able to use transportation network like Uber and Lyft for non-medical transportation. Now, that's not going to really help those of us who use wheelchairs, because those companies don't really have wheelchair accessible options, but it will help a lot of other people who don't use wheelchairs. Even taxis are getting really difficult to use. Unfortunately, I think the TNC network has kind of wrecked the taxi industry. But we will be able to, so I think, and that's sad, but that's what it is. So I think this will help people get around. Senate Bill 22-181 provides grants to transit districts, notably RTD, to partially fund 30 days of free transit to get more people to use transit. That's going to be happening in August. That's also good for the air. Anything that promotes transit is a good thing, although it would have been nice if they had fully funded that instead of very partially funded that. And Senate Bill 144, we did a lot of amendments in that. It was focused on the use of transportation network companies for school transportation, and they were not being regulated at all, which is a huge problem. We added some safety requirements such as background checks and GPS tracking, and letting the parent have the GPS tracking. And there's going to have to be a number of rules, and the PUC is going to work with CDE and any interested advocate on the rulemaking. You can go to the next slide, please. The bills we were very excited about are 2 bills on durable medical equipment, particularly around wheelchairs. House Bill 1290 was focused on Medicaid. This is all to speed up repairs of wheelchairs. So one is they're getting rid of prior authorization for wheelchair repairs. There's going to be a 25% increase in rates for rural repairs to offset the travel costs. And then HCPF and stakeholders will meet to identify metrics for appropriate quality, including timeliness of repairs, expectations to stock parts, all of that. After 3 years, HCPF will have the authority to issue fines to manage performance. I think people are very well aware, people who use wheelchairs are very well aware that we've had some significant quality problems with vendors. And HCPF has taken a ton of complaints, but they didn't really have a tool. All they could do is call, and it's mostly one provider, but a very large one, is call the provider, with every single case. And that's only the people that got to someone at HCPF. And so now they're going to have an appropriate tool to regulate these companies. The bill that's gotten the most press nationally is House Bill 1031, which creates a right to repairs for wheelchairs. This is not limited to Medicaid. It's the first in the country. It requires that manufacturers have to give us manuals, programming information. If there's like weird tools, like a bolt that you can't find in a hardware store, they're going to have to give us those things, and they're going to have to sell us parts directly if we want to do that. And that's just another option. Not everyone's going to use it. Some people don't want to repair their own, but some people do. So we're very excited about this pair of bills. If you can go to the next slide, please. And then there were 3 bills that I kind of put in the category of protection. Senate Bill 79 requires dementia training for facilities that serve, or facilities providers that serve people with dementia. I think that the impetus was some of the press stories of people with dementia being really badly abused because people not understanding it. Senate Bill 154 creates some accountability and a modest increase in fines for abuse and neglect by assisted living facilities. It also establishes increased training requirements, grievance procedures, and requirements for some standards for the people that administer them. And Senate Bill 203 is the PACE program bill, and that creates some oversight requirements and ongoing financial monitoring of the PACE program. Since that program went for profit, the costs have exploded. And so this will let HCPF be able to monitor the cost and make sure that the payments are appropriate and that the payments are going to the clients, to client care, as well as additional oversight, which is needed. There were some quality issues and a pretty severe audit finding this year that HCPF has been working on. So that is so I'm going to turn it back over to Sarah now, I believe. Thank you, Sarah.
Yep.
Great. Yes, if we could just go to the next slide. So this is Mary. This is actually a little bit of an older video, so people are wearing masks. It was done during the pandemic safely. And also highlight some of the work that she's doing in the community as well. So I'm actually going to highlight her during our all staff meeting later today because she's helping us do some accessibility testing on Peak and has identified some defects for people who are using screen readers to access Peak. So making a pretty huge impact on our work. She's also a former Member Experience Advisory Council member and Family Voice Council at the Department of Human Services. So if we could just hit play and we'll hear Mary's story.
I spent my life before Health First Colorado just sitting at home. Too afraid to go anywhere because of the fear that if something happened to me, I would have a $6,000 hospital bill waiting for me, which I couldn't even pay a $100 doctor's bill. Health First is awesome because it provides help to people who, like myself, are disabled and low income and don't have any other method of taking care of ourselves and paying for our health care. Since I have Health First, I don't have to worry or what if X or Y happens to me. I can just say, you know what, put the what ifs away and go do something with yourself. Project Angel Heart is special because they're very accommodating to people with disabilities. They accept people regardless of, what their abilities are. Volunteering, it's really hard to find places that are accepting of others, especially with a disability. And Angel Heart was like, yeah, come in, My life is awesome with Health First because I don't have to, it's basically less worries. I feel a lot better, having it. I wouldn't be able to do, what I'm doing. I mean, I would not have the help I have, and I'd be beyond financially strained, and I wouldn't even know what to do. Health First is so important to me.
Thank you, Sarah.
Thank you. And I will put a link in the chat to the playlist that has all the videos. So if anybody's interested in checking out the rest of them, we also have some sharing toolkits. So if you want to share some of these with your networks, you can reach out to me and I'll get you connected with those toolkits.
Awesome.
Thank you.
Just fantastic video, Sarah. Thank you very much. All right. I know we have about 5 minutes left, so let's get through the housekeeping here quickly. If we can go to the next slide, please. Wanted to remind everyone on this call, I know a lot of you work directly with agencies or have different organizations that you partner with. We are really wanting people to get this information in as soon as possible. We still have a lower than anticipated return rate for our attestation for the new base wage. And we want to remind people that if they do not attest to passing that through, there will be audits followed by potential recoupment of funds. So there are repercussions for not pushing this forward. This was part of the agreement we had with JVC. It's in regulation, and it's something that we worked hard to really make sure people understood was that this increase was for the direct care worker. And we had some flexibility around that, but at the end of the day, this was to increase wages. So we want to make sure that is being done. So please make sure if you have the ability to talk to any organizations that are in the provider sphere, that they are going about and doing this. Go to the next slide, please. Just wanted to remind folks on the Health Equity Task Force planning sessions. Next one is July 13th. All of the links there are available for you if you'd like to put those on your calendar. Great opportunity. Erin does a great job. I'm hoping more people can get involved there. Go to the next slide. Our annual webinar. So our director, Bimsteffer, does this every year, typically in July or August. Goes over everything that we've done the last year, look at what we're trying to do this next fiscal year, what we're looking for sort of more broadly in the healthcare space. Bonnie will be there doing some presentations on the work that's being done at OCL, in particular around ARPA and some of the other things that we have going on. But please put this on your calendar. It's a great opportunity to really get engaged with the entire department, to look at what's going on in different spaces, whether that be eligibility or our health information office, and wanted to make sure that people have that information there as well. So you can register for that, and that will actually just pop up in your calendar if you'd like. And with that, we'll have a minute or two for questions or discussions. Julie, did you have anything that you wanted to add here before we wrap up?
No, thank you.
Yeah, thank you. Any questions on the phone, or anyone want to raise their hand or pop off the mute? Okay. As always, if you go to the next slide, please make Max happy today and fill out our community survey. It will take you 60 seconds, and really it makes Max's weekend. So we want to send him into the weekend with good vibes. The feedback survey he just posted there in the chat as well. But it really does actually help us. It really does help us be able to understand how this is working, if we can improve on anything, if there's different kind of multimedia ways we can engage people. So please, if you have a minute, that would be great. Next slide, please. Our next webinar, I misspoke, it's not in July, my bad. It's in August. I know we take July off. A lot of people are out, justifiably so, enjoying the summer, spending time with family. So we'll do a quarterly update on August 18th. And then we'll have our next general meeting on the 15th of September, which seems like a very long ways away from now, but I'm sure it will come up very quickly. I can't believe we're already mid-June right now. So keep an eye out for those. We'll obviously send emails through John Berry. And the last couple things, if we could just stay engaged, we've actually been getting a lot of questions about how people can join the email list. All of that information is right here. If you'd like people to receive those emails from John or get broader departmental updates, all of that's right there. Our memo series, a lot of important information that flows through there. So please make sure you're signed up, or if you have anyone in your life that is interested in the work that we do, interested in healthcare, long-term care, or any of the ARPA projects for that matter, please take a look at that and share that slide with them. And with that, I want to thank everyone for their time today. I hope everyone stays cool and has a great weekend in the next couple days.
Happy Juneteenth, everyone.
Yes, thank you, Julie. Good call.
Thanks. Have a great day.